it just come up? There we go.
Yeah, there you
All
go.
right.
It started.
So I'm going to turn my camera off and mute myself, and I'll let you kick off.
That's fine. I think once I'm sharing my screen, I won't be able to sort of see if there's any hands and bits. So Lucinda, if you don't mind just keeping an eye on the chat for me and just interrupt me if I need to stop and go back or explain anything. I'm quite happy to do that as we go, especially since it's quite a small group. I'm happy to make that quite informal. So I'm just going to start off by sharing my slides. Can somebody just unmute and tell me whether you can see them?
Yeah, that's perfect.
Perfect, lovely, thank you very much. So I'm Philippa. I think I can recognise a few names on there, but I think there's some of you that I've not perhaps met before. As Lucinda said, I work with her at the Training Hub, but I'm also a pharmacist by background. I've been an independent prescriber for about 10 years-ish, I think. Worked a long time in secondary care, and then I've been in primary care for some time now, about 6 years. I run clinics in general practice as well, and I also do work with Health Innovation England on their polypharmacy programme. And part of that polypharmacy programme, we talk about shared decision making and the importance of involving our patients in shared decision making. Now, hopefully, shared decision making is something that you're all familiar with already. But when we've been doing the polypharmacy sessions on the national programme, it's become really clear that actually it's something that people perhaps think about but don't necessarily do as well as they could. So hopefully today's session is a bit of an update on what shared decision making is. I've also got some Slidos in there, so if you have got a mobile handy, that would be really, really helpful. If I'm guessing everybody's got a mobile. If you really haven't and you can't join the Slidos, then perhaps pop your answers in the chat so that you're still engaging in the session. I basically just want to make sure that you're not all falling asleep on a Friday morning. Hopefully you've all had a tea or a coffee or something to keep you awake and you weren't up all night watching the election. So crack on. So for the session today, I'm going to talk a little bit about what shared decision making is. Equally, what shared decision making isn't, because I think that's just as important to understand. What the drivers to that are, what the barriers are, because I think sometimes it's difficult to achieve, and I don't want to put, I'm going to ask you what you think the barriers are, so I'm trying not to put words in your mouth right now. Talk a little bit about the relevance to practice, some of the medico legal implications of shared decision making, perhaps something that you've not considered in that much detail before, but really important, I think. And then talk about some of the consultation models and tools that you can use to support your shared decision making in your everyday practice. So, oh, hang on, have I skipped? I think I might have just skipped a slide. Okay, so I'd like to start by, if I'll just give everyone a minute, if you scan the QR code, you should be able to do the Slido, but you can do it online as well, actually, and you're obviously all joined online anyway, so you might be able to open a separate page on Slido and just put in the number there. As you all answer, if the magic of this works, it should come up. Okay, someone's answered. So I know it's now working. So if other people could pop their answers in, I'll give you all a minute to be able to answer that. So good to see that our initial answers are sort of most and always. So the downside of this is I can't see how many of you have answered, so I'm just going to give you a couple more minutes. Beautifully segued into Mike. I've just had a coffee delivered, so I'll take that. Thank you very much. So great to hear that everyone's doing. Yeah, I've just realised that always the most of the time. Clearly, I was not fully awake when I did that questionnaire because they're pretty much the same thing, aren't they? But everybody's doing it a lot of the time. So go on to the next slide. So I'd now like you to think about what are the barriers. So I know you're doing shared decision making most of the time or always, but what do you think are the things that stop people from doing shared decision making? I'm sure you've seen consultations in the notes where it's not been done. And I think if we're all honest with ourselves, there will be times where we've not done it as well as we would have liked. And I think that one that's just come up would definitely be my number one as well. And it is that lack of time, isn't it? It's really difficult to go through all the options with your patients in a very short consultation, especially when you know you've already got the next patient waiting outside and this patient has already asked you about lots of other things as well. Yep, so time. Language, yeah. So you're thinking, so language, are you thinking the language as in sort of layman's terms, or perhaps language communication barriers if the other person speaks a different language can be really tricky? Compliance, communication. Yep, I definitely agree with all of those. Yeah, I think some of the other things, I know people are still typing, but I'll just talk while people are thinking about that and trying to put things down. The other things that I think can be quite sort of difficult, and where I see it go wrong a lot, is where you've got less experienced colleagues. You might see that they perhaps lack the confidence to offer the patient multiple, particularly if there's a nice guideline saying this patient should be on drug X, that then they're more inclined to just go, well, let's give them drug X and not give the patient a choice in that, because they've not got that confidence to personalise that care for the patient. And I think sometimes incentive schemes play into that. There's certainly CQC searches, for example. I know there's a CQC search that says that people on certain drugs and with other risk factors have to be on a PPI. It should still be a personalised decision. And how often do you actually give the patient that decision? Or do you go, I've got a report, I've got an achievement target, I have to put them on this drug, and forget to give them that choice and that shared decision. And I think one of the other things that sometimes comes up when we ask this question, particularly on the national programme, is around people being worried about complaints or litigation. So if I let this perhaps elderly patient that really just doesn't want any more tablets have that decision, are their son or daughter going to come into the surgery and complain that I've not given them that medication or I've not made them take it? And so there's sometimes that concern about that coming back as well. So yeah, absolutely. Loads of really, really good points there. Health beliefs, I think, is a really important one. The patient's understanding, I think, is really, really important as well. And sometimes the patient doesn't want that understanding either. So, you're kind of blocked by what you can achieve there as well. So thank you for getting involved and writing lots of good things down there. So I said I'd talk about what shared decision making is, but before I went into that, I wanted to talk about what it isn't, because these are some of the things that come up. Is that particularly your very old school clinicians, and I'm sure we've all worked with them or know somebody that fits that description, will say, well, it's just niceties. We're the health professional. We know what's right for them. We should just do it. And I think that attitude is very much changing. And the fact that you've all said that you're doing either most of the time or all of the time, none of you are of that ilk. But it isn't just about being nice. It's not about going, well, it's up to you. You decide, you tell me what you want, and just kind of like absolving yourself of all responsibility. It's about having that two-way process and supporting the patients on their priorities to make the right choice for them. The other thing that it's not is a means of saving money. As I said, this is part of a bigger programme of work around polypharmacy that I've been working on, and I'm a big believer in stopping medicines, which might seem ironic for a pharmacist. And sometimes what I get back is, oh, you're just doing that to save money, and it isn't about that. It does save money, and I think that's a real positive, but it's not about that. It's about having the right person on the right drugs. And it's also not a free-for-all. It's not saying that your patient with chronic pain that's not responding to their opiates just gets to demand more opiates every single time because we've created an addiction in them. That would be clinically inappropriate. So it's not about a free-for-all and just giving the patient what they want. We're still the clinician, we still have expertise, but we also need to listen to our patient and their priorities. So what is shared decision making? So there's a government paper from King's Fund, and you probably have heard this before: no decision about me without me. And I think that's really important. And I quite like this. You may have heard of Tricia Greenlaw, quite sort of, I can't even think what her role is, but she's very active on Twitter and quite senior somewhere in the NHS. And I quite like this because we've all heard that, don't confuse your Google search with my, I mean, in that instance, it's 6 years at medical school, but that equally could be all of the years that you've done doing your nurse training, or as pharmacists, the years we've done doing pharmacist training. And we can be quite dismissive of people almost, I've studied for this, I know this, you've just done a Google search. However, equally important to our study is that patient going, don't confuse your 1 hour lecture on my condition with my lifetime of living with it. And I think that's really important to recognise. And I think that's something that nurses particularly do a lot better. Certainly the medics. I'm just going to leave pharmacists out of this because I am very aware that I'm incredibly outnumbered on this call. But the shared decision making is about combining those clinician expertise with the patient's expertise bits as well. So I wanted to talk a little bit about what drives shared decision making. So we've got everything from international drivers. So the World Health Organization, their Patient Safety Day last year, so that was last September, was all about the whole theme of the whole day was around elevating the voice of patients. It was about listening to patients, engaging with patients, empowering patients and their families to be actively involved in their own healthcare and the improvement and safety of healthcare, about advocating for patient and family engagement. So it feeds into the global, you can tell I'm reading this bit because it's like obviously the kind of their mission statement for the day, but it feeds into the global patient safety action plan, which is running by the World Health Organization over a number of years from 2021 to 2030. So we're kind of in the middle of that at the minute. So it's sometimes easy to forget that the little bit that we're doing day to day is part of a much bigger international picture around patient safety. And that actually the work you're doing and the fact that you're doing shared decision making and doing it well already is you're playing a really important part in that patient safety across the world, really. And then more nationally, coming sort of a bit closer to home, there's guidance from NICE around shared decision making, and that was published a few years ago, and you may be familiar with that already. And that's it's not a very useful guideline in terms of what you do day to day, but it's more aimed at systems, I would say, about underpinning shared decision making and what you put in process to ensure that that happens within a team. So if you're managing a team, it's probably more useful. If you're just looking at your individual practice, I would say possibly less so, although there is stuff in there about sort of signposting to decision making tools and bits, which I'll talk about a little bit more. So I've alluded to polypharmacy, and I think it's really important to talk about polypharmacy in conjunction with shared decision making, because I think as health professionals, we're very good at treating things, about giving people things. Like we want to fix things, we want to make things better. You don't go into healthcare because you don't care. You go into healthcare, you know, none of us are here for the money. You go because you want to make a difference to patients' lives. And I think that the society that we live in and our culture is that we want to fix problems. We want to do something. And so it always feels better to give somebody something than to perhaps take it away. And I think that's a natural thing that we almost have to fight against. And there's lots of papers at the moment saying that polypharmacy is, that we have an epidemic of polypharmacy, and that this is due to a number of things. One is to do with the rise of multimorbidity. So there are more people living with more complex conditions. We have an aging population, and as people get older, they get more conditions. So that follows. It does add avoidable costs to the healthcare system, not just the cost of those drugs, but also the environmental impact of both producing those drugs and dealing with the waste of those drugs, and also the avoidable hospital admissions that result. So the more medicine somebody takes, the more polypharmacy that exists, the more likely that you have avoidable hospital admissions. And good shared decision making reduces polypharmacy, because often patients will make decisions to not take tablets where perhaps a guideline says they should. And we'll talk about that a bit more as well. So I thought it was really important to talk about consent. Now, I think sometimes as healthcare professionals, when we think about consent, we think about a procedure, about doing something to a patient, or maybe a clinical investigation. You think about asking your patients maybe for consent before you take blood or before you do a blood pressure. But actually, consent to take a medication is just as important, and actually arguably more so, because if you go to do blood pressure and you've misunderstood that consent, they're just going to pull their arm away and go, no, sorry, that's not what I meant, you can't take my blood pressure. Whereas if you give them a medicine and they don't fully consent and they're not on board with that decision, it's just going to go to waste. And then obviously, you know, there's no you're not in that patient's home. You know, we're in primary care. It's not like being in hospital where you can check they've taken it and stand over them until they've swallowed it. I mean, even then they can spit it out. And, you know, many of you may have had backgrounds working in secondary care at some point. So you'll be aware of the patients that keep them all in the cheek and then spit them out when you're gone and hide them all under the pillow and you find it when you change the sheets. But even more so in primary care, and certainly you only need to go into any community pharmacy and ask to see their returns box, and it is a hideous, absolutely massive pile of medication that is returned. So we know that a lot of patients are not really on board with consenting for their treatment, because if they were, they'd be taking them. So they're obviously not taking them, and there's got to be a reason for that. So we either need to make sure that they're engaged enough that they want to take it, that's great, or that they've been given the opportunity to say no. And I think if we get that right, that massively reduces that risk and that waste. And I think the waste really upsets me, because it's just pointless. It's not helping anybody. But going back to the sort of legal side of things, and the consent side of things. So I'm not sure. Can you just put up your hand if you already know about Montgomery judgment? Just change my screen so I can see you. Okay, so I will cover it very quickly now, but I won't spend ages, and Charlotte, you'll just have to bear with me and then maybe come in and correct me if I get any of this wrong. So prior to Montgomery, we had, you might be familiar with the Bolam test, and the Bolam test was that if we did something wrong as healthcare professionals, the Bolam test said, as long as we had done something that a professional in a similar training, similar background would have done the same across our profession at a similar level, then that was acceptable. And actually, the Montgomery case was around a lady she was a diabetic lady, and she gave birth by vaginal delivery, and her baby was born with serious disabilities because he had a shoulder dystocia during delivery. The doctor hadn't told Montgomery, Nadine, the mum, about the fact that there was a 9 to 10% risk of this shoulder dystocia. And the doctor said that she didn't routinely discuss this risk, and it wasn't routinely done. So if you apply the Bolam test, then essentially she had done her job. But what the Montgomery ruling did was that, and the court held that the doctor should have told her about that risk, because it was important to her and it was important to her baby. And so that was a material risk, and material risk is something that's important to the individual in front of you. And as a result of that case, and the baby very sadly suffered brain damage as a result of this shoulder dystocia, she was awarded £5.25 million of compensation, which obviously nothing really goes to compensate if you've had something so catastrophic happen. So I mean, there was a 16-year legal fight, so there was a lot that went on. The law now states that healthcare professionals have to take reasonable care to ensure the patient is aware of material risks in any recommendation of treatment and reasonable alternatives and treatment variants. So if you're applying this to your prescribing decisions, that's a treatment, so it's just as applicable. Your material risks might be the side effects. So what I find quite helpful to think about is what's important to the patient in front of you. So if you've got drug X, for example, I'm not going to use an example because I'll end up tying myself in knots with it. I'm not going to use a specific drug, but let's just have an imaginary drug X, and you've got a patient that's maybe a 10-year-old boy, and you've got a 30-year-old newly married lady. Now, if one of those side effects is teratogenicity, the material risk to the mother is about the teratogenic effect, but to the 10-year-old boy, that's irrelevant. But if maybe drowsiness is a side effect, then that might be relevant for both of them, for example. So it's thinking about what the material risk, what is the impact of that patient, is personalising that decision and the information you provide, because you can't give a patient every single side effect on the leaflet, because A, nobody's got time for that, and B, most of those might not be relevant or important or provide a material risk to that patient in front of you. So it's about that personalisation of that discussion. So this is a bit of a summary of sort of the Montgomery judgment in practice, and there's some good guidance from the Medical Defence Union, and the GMC have also provided guidance on this. And essentially what it says is you need to find out what's important to your patient. And again, I think nurses are better at just knowing this stuff and knowing their patients very well. and thinking about what those relevant harms and benefits are of that option and what those alternatives are. And it's reasonable alternatives. So like I said at the beginning, shared decision making isn't about a free-for-all, it's about having reasonable alternatives. So I think we've sort of covered some of this already. So it's things that are probably going to be significant to this particular patient in front of you. So that's the legal basis, essentially, of shared decision making. The other big legal case that I'm sure everybody is aware of and has heard of, because we've all had our Oliver McGowan training, is about Oliver McGowan. And you'll all be aware that essentially Oliver very sadly passed away and was autistic. And a lot of that training is around awareness of disabilities and listening to carers. And actually that listening to carers and that shared decision making, had that shared decision making happened properly with his parents and carers, that perhaps it wouldn't have been such an awful outcome for Oliver. And some of the learning from that is around the Ask, Listen, Do campaign. And this is just some information from the Oliver McGowan webpage and training. And the statement that they put out is that they believe that those principles about ask, listen, do are so important. And that's one of those consultation models that can be used to implement shared decision making in practice. It's about asking people, and obviously specific to Oliver McGowan, that's asking people with a learning disability or families and carers, but this applies to anybody regardless of if they've got a learning disability or not. Listen to those involved, show respect for those opinions, and do something about it, work in partnership with them. And as it says, put people at the heart of all decision making and respecting their point of view. And certainly as part of prescribing courses, we've all done work around the medical legal aspects of consent. And just because somebody makes a decision that you don't think is wise, if they have consent, that's still their decision to make. And same goes for consenting for taking a medicine. So that's the Ask, Listen, Do model. So I think I've kind of gone through that already. So I'll go straight on to the next slide. This is another one which I think is a really good one. I mean, similarly, it's that 3-step model. And this one's from the BMJ, and it was a huge consultation process that they did. They looked at lots of different studies, lots of existing consultation models, but tried to embed shared decision making into them. And they came up with this cycle and I like the fact that it's a cycle because it keeps going. So you kind of start with your team talks and working together with your patient, thinking about what's going to work best. And the other thing I like about this, and if you look at this BMJ article, it gives more sort of in terms of the vocabulary that you can use and sort of simple statements to open those conversations. So some of those are on there. So let's work as a team to make a decision that suits you best. And then looking at the alternative. So let's look at what the possible outcomes are, and then tell me what matters most to you for this decision. And you kind of can keep going around that cycle to get to where you need to be. And I suspect some of those statements, given that you're all doing a lot of shared decision making already, are things that you may have done already. But I think it's quite helpful to reflect maybe and go, do you know what, actually I'm good at maybe step 1 and 2, but maybe 3, I kind of, by the time I get there, I've just decided what I'm going to do based on what they've said so far. So maybe that's something that you could improve on, because there's always something we can all improve on, hopefully. So next I wanted to go on to what tools are there out there. So there is masses of stuff out there, some of which you may have used, and I really do appreciate that time is really tricky to be able to utilise some of these, but sometimes having these available to you can be quite helpful. And what I've done in consultations where a patient's very engaged and wanting a lot of information, and I can see the time's ticking past and I've already run over with them, is sometimes I'll give them these tools to go away and look at and just ask them to come back when they've made a decision. So give them maybe the bones of that information that they need to make that decision. But for example, I've sent people who've been very maybe statin reluctant. They've maybe said no at that initial consultation, but rather than just me going, okay, fine, I'll code your statin declined, I've sent them away and said, have a look at the statin decision making aid and see if that changes your mind, and if it does, come back to us. And I might decline them as statin in the meantime, but at least I've left that door open for them to come back and provided them with a bit more information to make an educated decision. Number needed to treat is something that's well worth looking at. If it's a web page you've not come across before, it looks at exactly that, the number needed to treat to have a positive outcome. So depending on what the indication is. So for example, I know Chris is doing a talk on menopause later. There are slightly relevant. there are, I think there's one on allogenate, but it's got for postmenopausal women with fracture versus premenopausal women. Like, what are the benefits? Actually, how many do you need to treat? Is it actually worth treating? So you can look at different patient cohorts and different indications. And that's based on all the trial data. So it's really evidence-based, good way to see, actually, is my prescribing what it should be? So that might be a good one to use if perhaps you are doing your clinical supervision. Maybe you've audited your last 15, 20 prescriptions, or however you do it in your practice. You might want to go back and then go, do you know what? I'm going to look at these drugs. What did I use them for? What was the number needed to treat? Am I happy that that was the right thing to do? And use that as a learning tool as well. There's a lot of polypharmacy guidance. I've just included that one. It's a Scottish page, but it's really, really helpful. They've got loads of brilliant flowcharts around deprescribing, when it's appropriate to deprescribe, how it's safe to do that on lots of different drugs. And actually, maybe if you're working with less experienced colleagues, it's definitely a good starting place perhaps for them if they're less clinically comfortable with suggesting stopping medication, and it might sort of help support them in that decision-making process. Similarly, if it's an area that's maybe outside your normal practice and something you're less confident with, having a nice flow chart to follow and guide you through so that you know you've considered everything you should is really helpful. There did used to be an app, and I have got the app, and I tried to search for the app on the App Store, but I couldn't find it, so I'm not sure if you can still download it or not, but it is worth having a look, because if you can, the app's quite useful, because obviously you can have it on your phone and check it a lot more quickly. GPevidence.org is another good one with, again, like the name suggests, lots of good evidence. There's lots of guidance, and there's some bits in these slides that I've taken from there around guidance, around shared decision making as well. They've got some good statements and advice about shared decision making too. MeandMyMedicines.org is a programme that is being run by Health Innovation England. Health Innovation England is a new name for what was the Academic Health Science Network, or the AHSN. And that programme is around getting patients involved and wanting to ask questions. So if you're doing medication reviews, so as pharmacists, obviously we do a lot of this, we now send them this information prior to them coming for their med review, and it gives the patient, the aim of it really is to help empower the patient, but it gives the patients questions to ask, or things that they might want to ask, so that they come in really engaged and ready for their med review, rather than just coming in and going, don't know why I'm here, everything's all right, you know, I'm sure it's fine, like, you know, and then having to get that engagement before you can even move on to making a decision. So what I'd encourage you to do is think about what consultation models you use already. We all have developed our own systems to help us work efficiently and safely, but think about, how does decision making fit into those? And you may have done that already, you may be doing that well already, but you may think, actually, I think I maybe need to work on this part of it or that part of it. And how could you use those tools? Is it something to use as part of your consultations? Is it when you're reflecting on your prescribing practice in your clinical supervision, or is it something else that you could use these for? So what does all this mean in practice? Ideally, we should be preparing for our consultation. Not sure who gets time to do that. I think mine is 30 seconds before the patient walks into the room, is perhaps scanning through the notes, looking at what they're on, trying to figure out, have we got the appropriate monitoring in place? You know, is this working for them? Having that discussion as much as possible. Thinking about, how's your patient had the opportunity to prepare? Have reception rung them and told them why they're having an appointment with you? So have they come ready? You might be doing specialist reviews, so you might be doing asthma reviews or diabetes reviews. So, you know, does the patient know what they're coming for, so that they can come prepared with their questions? You know, if they know it's an asthma review, have they come thinking about their inhalers, and actually, you know, how do these get on? Thinking about trying to unlock those conversations, the language you're using, finding out what really matters to the patient. Some patients are very taken aback when you ask them what matters to them, and you may have come across this yourselves as well. What matters to me? I don't know. Why are you asking me that? So ICE, obviously, I'm sure you'll all be familiar with ICE as a consultation model. So it's exploring the patient's ideas, their concerns, what's their expectation, what are they hoping to achieve? So chronic pain reviews, which are the bane of my life. I don't think anybody enjoys doing them because they're really challenging. And actually, sometimes I get patients, well, my expectation is that I will have no pain. And so the answer to that is actually that's not an achievable expectation. So sometimes, and actually 9 times out of 10, patients are actually grateful for that honesty, that they're chasing something unobtainable. And I think they almost realise that themselves, but they're still hoping that it might be achievable. And I think that's human nature. It pays to be silent. And I know that's really, I really struggle with this, especially when I know I'm overrunning, to just sit there and not say anything, to give the patient that chance to speak. BRAIN, I think, is more used in sort of obs and gynae, when I've come across it before, but BRAIN stands for the benefits, the risks, alternatives, so what else is available, intuition, what does my gut say? And again, I think as clinicians and senior prescribers and AMPs, you've got the experience, what feels right for that patient as well, but also asking the patient, well, what, and the patient, I don't know, what do you think? Well, what did your gut tell you? That I really don't want to take another tablet. Well, listen to that with the patient's intuition as well. And then nothing is the N. And I think nothing is really important as well. What happens if you do nothing? Probably not a great deal. Ambits. And then the population health versus the individual health of the person you're applying it to. Again, really important. All of our guidelines, all of NICE, everything, all of these CQC searches with targets, our QOF targets, all of these things are based on population health. But how does that actually apply to the patient that's sat in front of you? Is it actually relevant to them? Is it really going to make a difference to their life? Normally, we can exclude people by saying that they have declined. It's really important that you document why and that discussion that you have had with them, but it is okay to do that. And that obviously brings perfectly onto the document. It's really important to document those shared decision-making conversations about how you've come to that conclusion, about why you've come to that conclusion with the patient, and making sure that the patient's on board with that decision. So it's perfectly okay to end up with a, no, I don't want to take this tablet. So I mentioned earlier there was some good guidance from GP evidence, and I've got it here because I think it's really, really helpful. So I think most of us feel a pressure to follow condition-specific guidelines, and condition-specific guidelines are for, as that term suggests, a specific single condition. How often do you see a patient who has a single one specific condition? Not often, right? So a lot of the time our patients are more complex. So we need to think about, well, okay, that guideline says they should be on that drug, that guideline said they can be on that drug, but actually there's drug C here that would do both of those things and might be better for them than taking 2 separate drugs. So, maybe there's a compromise to be made. And sometimes those guidelines and the pressure to do what NICE have told us to do for that condition, and then for that condition, and then for that condition, mean you end up with this polypharmacy rather than thinking about your patient holistically. And so it can hinder that ability to make those appropriate decisions for that person in front of you. And let's be honest, it's much, much easier to just look at one condition at a time. And when you're under time pressures and you've got a million other things in your head that you've got to get done that day, that's easier to do. And so that's human nature as well. So I think it's really important to remember that guidelines are an important reference point, but they are guidelines. They're not tramlines. We don't have to do it. They are guidance. They're not law. They're guidance. And it's really important that we use those to maybe facilitate that conversation. But that bottom line at the end, I think, is really, really important. It is acceptable and indeed often very good practice not to directly adhere to a particular guideline for an individual. However, you must document that decision really clearly in the notes. And what's really frustrating is where you have documented it and then someone undoes it and just comes along and gets rid of all your amazing shared decision making that you have put in place for your patient. But hopefully that won't happen if you've documented it well and your patient is engaged in that decision. Then they're more likely to advocate for themselves as well, because you've given them that control or that power or that autonomy over their healthcare, which is what I think we all want to achieve as well. So I was told I had to get to 10:45, so I've got a couple more slides, but the next one, I think, just to kind of is a good way to sort of put some of this into practice. And I want to put yourself in the position of a patient. Imagine an ideal tablet. So this doesn't exist. No tablet is ideal. But just for a second, imagine it's an ideal tablet. So by that, I mean it's free. Nobody has to pay for it. There's no cost to the wider economy, to the government, to anybody. It's just free, magic medicine. It's got absolutely no side effects, nothing at all. Obviously, we know that doesn't happen at all. There's no interactions. So it's not going to make any difference to whether you take it with food, without food. It's really easy to take. It's not going to interact with anything else you take, none of your other conditions or comorbidities. You don't need any monitoring. So it's absolutely perfect. Now, it can add time to your life, but you have to take it. So the only downside is that you have to take that tablet once a day for the rest of your life. So for that very tiny minor inconvenience, or you might say, well, actually, that's a bit of a pain in the arse, frankly, and actually, I'd probably struggle to do that. So to be absolutely religious and take that tablet every day for the rest of your life, to commit to that, how much additional lifespan would you, as an individual, I can't see who's answering what here, so don't, nobody's going to quote you, but how much lifespan would you want to see on your life? Someone's straight in there with 5 years. More than 10? This is a perfect drug that doesn't exist. This is tricky because I don't know how many of you have responded already, but I'm just going to give it a couple more minutes because it looks like they're still moving. So, I mean, it's close there, but we're definitely leaning towards more than 10 years for a perfect tablet. So if I told you that analysis of all the statin trials have showed that for 99% of the population, they would gain less than 2 years longer lifespan by having a statin lifelong. How many patients have you given a statin to and not considered this? How many of you perhaps are already taking a statin, which does have side effects, that does need monitoring? Now, I'm not suggesting that you all go and stop your statins, but I think it's really, really important to just think about and often referred to as medicine disutility. So what's the trade-off between what benefit we're going to get versus the inconvenience or potential harms? And I think that really shocks everybody when they actually put themselves in that position and think about it. And we don't think about it like that. But really, I think our nature to start things, I kind of wanted to end on something that makes you review your decision to stop things and perhaps empowers you more to be more confident about stopping things or more comfortable with patients that make that decision to stop things. Because I think sometimes the nature is that somebody, we particularly with statins, there's so much about statins, and we've got all the cough indicators now about statins as well, which is why I use that as an example. And those really drive that, is that shared decision making almost comes around, well, okay, if you're not going to have a statin, you're going to have ezetimibe, you're going to have bempedoic acid. Do I need to think about inclisiran? So we think about those as the alternatives, but nothing is equally an alternative. Now, again, I'm not suggesting that you just stop all statins, and we know that there's really good cardiovascular outcome data, but it's about what's happening to that patient, and it's about personalising that decision for the patient as well. So just going to end. I've got 3 minutes left. I've done so well. I'm so proud of myself. Is just take a moment to reflect on your own practice, the session today, and think about what you might want to do differently in your practice. Is there any take-home messages that you think, actually, I am going to have a look about how I do this differently? Maybe it's looking at some of those tools, and I will. When I finish speaking, I will go and I will put the links to those tools in the chat so that you've got them to refer back to as well. So you can just click the links. I know the session's obviously recorded, but hopefully having the links in the chat will make it a bit easier for you to access them. But just have a little bit of a think about that. And then just finally, obviously I've mentioned that I've taken extracts from the Polypharmacy National Programme. They are still running. There are 3 cohorts here that I've got info on. They are all free to prescribers and suitable for anybody that's prescribing as part of routine practice or doing any kind of med reviews. These are different dates. There's cohort 5, cohort 6 I know is already full, and then cohort 7 and 8, but the email addresses for Rich and Lisa, who coordinate those via him, are all on there. So if you are interested in doing a bit more about polypharmacy or a bit more about shared decision making, you would get a little bit of repetition because I've given you a bit of a taster today. Do feel free to sign up for those. And so that leaves 2 minutes for questions.
Very good. Any questions, anybody? Either pop it in the chat or turn your camera on and put your hand up and we can answer any. That was really excellent, Philippa.
Thank you.
Okay, so no questions. I'm just seeing how many people we've got. Really informative. I would agree, Sophie. We've got 15 minutes, so I kind of allowed people time to go and have a wee, get yourself a cup of tea and buckle in for the next session. And that'll be the same process. So I'm going to kick off at 10 till 11:45, and then there'll be a 15-minute lag, and then Chris will start again at 11 till 11:45. So yeah, I will pop my camera off and then we'll be back to kick off again at 10. There may well be other people joining, so because it's a kind of pick and mix, you can pop in and pop out. So I'll kind of kick off just after 10 to allow any stragglers to come in. All right. Thank you, Philippa. I'm really grateful.
No problem at all.
And I think that's a good session to repeat, because I think it's a really important one.
Happy to do so. It's written now, so. All right, have a good morning, everybody. I have put the links. They pasted like absolutely massive, so apologies for that, but you have got them there in the chat. I don't know if they look like that to everybody else, but the info's there, and obviously you've got the session recorded as well, and you're very welcome.
I think the decision aids is really useful tool I didn't know that was available, so I've learned something today.
There used to be a really good one on DOACs, which I used to use a lot, but they pulled it when the I just think I've become Phillips. It's all right, I'll forgive you, Charlotte. And then they pulled it because of the HASBED score being updated and different scoring mechanisms. But I have to say, I still use the old one because it's really helpful, particularly if you've got patients sort of changing. The statin one I do use a lot as well, which is why I've got that one. The DOAC one I think was around AF. So if you had somebody newly diagnosed with AF, it was about a decision to go on to a DOAC, sort of looking at the what I really like is the ones where some of them have got they've got 100 dots on a page, and each dot's a person, and they say so the AF one was really good because it said based on your CHADVAS score, if your CHADVAS score say was 3, for 100 people taking it, this is how many people would have an event anyway, and this is how many people would be saved. And then it did, if you had HASBED score of whatever, then this is how many people. So you could then people could look at how it affected them with their
and it's visual scores. And I think people do respond to visual things better than
visual
giving figures. And you're like, oh, what does that mean?
Yeah, and when someone's talking, only half of that goes into me. I need to see something visually. I mean, that's how I learn. That's how I take in information. So I think having the ability to use different tools, and I think giving things to people, like the statin one, I've had a few patients where I've given it to them to take away, and then they've come back and asked for a statin, even though they were adamant they weren't taking one. And bits. And I think it's giving them time to take in that information rather than just going, right, 2-minute conversation, do you want a statin? And them going, no, I'm scared because I know, like, my neighbour had muscle pain because they did too much gardening and it was actually nothing to do with their statin, but actually giving them that information. I think sometimes where we're time pressured, it's really easy to just go, okay, they've declined, that's their decision, and that's not really shared decision making. So there is a lot of good things out there, but
and I think with Accurix now you can share those instantly.
Definitely,
they can sit in their bed and scroll and have a little look at that rather than having that pressure of make the decision now. Because
I think we all know we've got a lot of patients that will go away and Google. Equally, there's lots that don't, but we know the patients that will, and I would always rather give those patients some robust decent quality data than risk them going off and finding some Facebook group with experts that really don't know what they're talking about.
That are talking about their lived experience, not actual figures.
Absolutely. Which has value to them, but perhaps might be very irrelevant to your patient. So it's giving them the information. And I always say to patients, I'm here to give you, a lot of patients come in, especially if they think you're going to stop stuff. They come in for their med reviews and they're like this. And I'm like, I'm not going to stop anything unless you agree to it. And they're like, don't believe you. And then as the consultation goes and you manage to engage them, I'm like, look, this is your decision. My job is to give you the information so you can make an educated decision about your health. But if you leave here not wanting to change anything, then that's okay. Because equally, I also know that as a pharmacist, if I stop something that they really, really strongly feel that they need, all they're going to do is go back on the duty list. The duty list isn't going to read my duty doctor's not going to read my consultation, as much as I would love to think they will. They'll have like 30 seconds to review that patient and they'll go, oh, just restart it. And then I'm like, so there's no point. It just, they need to be on board with that decision. And bits as well. So
Okay, right. I'm gonna put a slide up saying the session will start at 10, and then I will join you all back at 10.
I'll be off then. See you later.
All right. Lovely to see you, and I'll catch you next week.
Yeah, catch you next week. Bye, Lucinda. Have a good weekend. Bye.
Okay, right. I'm just going to share my screen. Last time I got the size of the presentation wrong. So this is not going so well, is it? No. Nicola, can you see that? Just going to give this another couple of minutes. Can everybody see the slide? Because all I can see is my screen because I haven't got two screens. Just see if I can get any of the screen up. Okie doke. I don't know whether anybody can just tell me whether they can see that and whether it's the right size, because I have a habit of making them the wrong size and they're normally too small. Can't even access the chat. 1 second. Okay, right, that's fine. I'm going to go back in. I'm just going to make sure that it's the right size because it's normally the wrong size. Lovely. Right. Okay. So, is that too big now? Okay. Okay. So, we're going to go through management of hypertension, and if you're new to prescribing in hypertension, I think this would be really useful to you. If you're not new to it and you're quite comfortable with it, I suppose it's a good way of just going over the AMP and the drug actions and how it works. 1 second, I'm just going to come back out again. That's why I need another person. Right, that's fine. Right, I just needed to check I wasn't muted. Okay, right. So, what we're going to cover today then is a recap of what constitutes blood pressure, kind of going back to your roots of AMP. I don't know whether you're nurses or paramedics or pharmacists, other allied health professionals, but we all at some point would have learnt how a blood pressure is created. So we are going to go back to basics. And then in primary care, what is considered hypertension? We're going to look at a review of the NICE guidance of the management of hypertension, looking at ACE inhibitors, angiotensin receptor blockers, calcium channel blockers, and thiazides. We're going to look at essential lifestyle changes for hypertension, and then we are going to go through some scenarios. Now, I've tried to do a Slido and I couldn't work it out, so it might be that we have to turn our cameras on and then we have an open discussion over the scenarios that I've done, and then any questions at the end. So, this is what constitutes blood pressure. I know that you all know this, but blood pressure is cardiac output plus systemic vascular resistance creates a blood pressure. And cardiac output has two variables: stroke volume, so the amount exiting the heart based on how hard it squeezes, and then the heart rate. And then systemic vascular resistance is the two variables are vasodilation and vasoconstriction, and blood viscosity. So we're going to keep coming back to this equation with all of the drugs. So I've got a quick 6-minute video, she says. Oh, that's not going to work. Great. Okay, we're not going to do a 6-minute video, but these are all embedded, and I will send them out to you, so you'll be able to watch them and catch up on them. So,
Lucinda, your slides aren't changing.
Oh, hang on. There we go. Is that better? Can you see that?
Too big now.
Oh God, this is what happened last time. Sorry, guys.
That's good.
If I do it from current slide, that's still too big? Or okay?
Seems to be okay.
Okay, good. Okay, so back to basics. The liver produces renin. Renin then is that makes your kidneys produce angiotensin 1. There is then a converting enzyme which converts, that comes from the lungs, that converts angiotensin 1 into angiotensin 2, and then you get vasoconstriction and secretion of aldosterone by your adrenal glands. So there's a lovely video in there that explains it all far more clearly than I do. And that essentially is how your blood pressure is controlled by the RAS system. And so all the drugs that we will be prescribing will act on one part of this process or another, or two parts of the process, but we'll come back to that. So what constitutes a blood pressure is if somebody's sitting in your chair, in your room, and you do their blood pressure and it's over 140/90 in clinic, that is considered essential hypertension. And so today's update is based on the patients that have essential hypertension. We're not talking about secondary hypertension. I've got another teaching that I've previously done on that. If anybody wants that, I can send you the slides. So if they are found to have a raised blood pressure in your chair, you would send them to do average readings. If the average home reading came out as above 135/85, that is considered essential hypertension. So I don't know how many of you have Accurix. I think most of us have Accurix now, but there is a florey embedded into Accurix that you can send out to patients, and it reminds them every single day, morning and evening, to take their blood pressure, and they can input it onto their phone, and that will then send it back to the practice, and it works out the average, and it can be saved to the patient's record. So the NICE guidance says that the minimum is 4 days, and you should discard the first day, but the ideal is 7 days of readings. And then once you've got that average reading and it shows that it's above 135/85, you would code them as essential hypertension and add a recall. If you don't know how to do that, then I'm happy to show you, but I'm sure there'll be other people in your practice that do other long-term conditions that will be able to show you how to add a recall. So when you have a patient that has essential hypertension, before you prescribe anything, you have to identify whether there is any signs of end organ damage. So basically, the fact that you have high blood pressure, it's exerting pressure through the vascular system of the brain, of the heart, of the kidneys, and the peripheral vascular system, and essentially causes damage. So what we're looking for is damage in those systems. So history of stroke, history of TIAs, vision loss, we're talking about papilloedema and inflammation at the back of the eye, heart failure, so that increased pressure all the time coming from a preload will be putting more pressure on the left side of the heart, and then because you've got this increased systemic vascular resistance the other side, you get basically an increased afterload as well. So you'll get dilatation of the left side of the heart. So what you're looking for there is to do an ECG, and you're looking for big R waves and you're looking for a widened QRS. Looking for renal failure, so you would be doing blood tests and you would be doing a urine ACR, so dipping the urine for protein and sending off for an ACR. I recently went. Yeah.
Sorry to interrupt you. Your slide's supposed to be changing.
Yeah, it should say.
We're still on the pretty picture of the RAS system.
Okay. Right. I'm just gonna have to get my husband. Sorry, I realise this is highly unprofessional, but for some reason this happened last time. Hang on. One sec. I'm really sorry, guys. I'm going to get some tech support now. 1 second. I wonder actually if I send it out to you, shall I do that? And you can do whether that might be an idea. This is because I live in the middle of nowhere. Second. Nick, can you
Yeah.
If I try and put the slides up, will you just be able to tell me real time what you can see?
Yeah, of course.
So can you see, obviously I'm not on slideshow now, but can you see those?
Yeah, we can see them. So you're now on your graft and now you're on your diagnosis and coding.
Okay, so maybe I don't do the actual slideshow. Maybe I just click through the slides.
Probably better.
I think it's the Wi-Fi. I think it's the fact that we're in the middle of nowhere.
It shouldn't make any difference. You won't be. It's changing.
No, because it happened. This is exactly what happened last time when I did the minor illness.
That changing?
No.
No, so I'm going to do it the other way. I think that's the best way.
Old school, Lucinda.
Yeah. Right. Okay.
That's something to really.
Can you right, so let's go back to actually where I am. So can you guys see this one, and is it the right size?
We can't that's it, perfect.
There we go. Okay, so ECG, you're looking for big R waves. You'd show that to your GP if you're not happy to look at ECGs. For kidneys, you're doing Usenes, you're looking for kidney injury, you're looking for a delayed GFR, a reduced GFR. And then peripheral vascular disease, you're looking for erectile dysfunction. So if they're male, you're going to ask them whether or not they are able to, or if they have any issues with getting erection or maintaining erection, and also intermittent claudication. So if they're walking, do they get calf pain? Does that calf pain settle when they've stopped walking or stopped exerting themselves? So let's look at the NICE guidance. So how many people have seen this or looked at this and don't feel frightened by it? I don't anymore, but I did when I first started prescribing in hypertension. So essentially, if you have a BP under 140/90 in the clinic, you just need to repeat it every 5 years. If they're found to have a raised BP in your room and that they have a home average as raised, then this is considered stage 1. So 135 to 85 and 149 to 94 is stage 1. And then stage 2 is 150/95. If they are under 40, there are a number of causes of secondary hypertension that have to be considered before you start them on medication, and they have to be ruled out. And if that is the case, then that's kind of a specialist evaluation, and this is looking for things like adrenal tumours and renal artery stenosis, all things that need to be managed in secondary care. So we're going to basically, and I've on each of my slides, I've cut and pasted to try and look at which part of this algorithm we are dealing with. So we're going to basically go through each of the drugs and talk about what the reason why you're going to prescribe it, what it does, and the considerations you need to have in the back of your mind if they have comorbidities. So the first one we're going to look at is ACE inhibitors. So these are angiotensin converting enzyme inhibitor drugs. They are for anybody that's non-Afro-Caribbean heritage that's under 55 and for type 2 diabetics. And when we're looking at this lovely equation, we're working on this systemic vascular resistance. So we are changing the constriction of the vessels, we're changing the blood viscosity. So it acts to inhibit the making angiotensin 2. So angiotensin 2 is basically responsible for smooth muscle contraction, of which smooth muscle is within all of your arterioles, your arteries. So that's its main action. But the secondary action it has is there is a loss of salt from the body. And so you get more urine excretion, you lower blood volume, therefore that resistance is less. Patients on ACE drugs, if they have any GI upset, if they have diarrhea or vomiting, either a bug or food poisoning, then you have to tell them to stop taking their ACE inhibitor. System 1 has a lovely leaflet. So when you're initiating patients on this drug, it explains to them when they need to stop taking their medications and the reasons why. And that's a really good tool to safety net and then document that you've done that. Again, if anybody wants me to do like a screen grab of where that is within System 1, I can do that and I can send that out. So mode of action. So ramipril, so the main drug for that we use with ACE is ramipril, and ramipril, and the metabolite is ramipril, and it inhibits angiotensin converting enzyme, which is, as I've said, the main vasoconstrictor, but it also promotes the breakdown of the active vasodilator bradykinin. So that then causes vasodilation. So it's important to understand that ACE inhibitors are less useful and are therefore not first line in the Afro-Caribbean population, and that's because their RAS system, their production of renin is less, and so when you're using an ACE inhibitor, it will not have as much effect as calcium channel blockers, and we'll go on to discuss that. So this is quite a word intensive slide, but these are the considerations you need to have. So as nurses, pharmacists, allied health professionals, we wouldn't manage pregnancy. For the nurses amongst us, we're not allowed to manage anything to do with pregnancy. So if a patient is pregnant and they have hypertension, that would need to be seen by a GP. However, I put this in because if you have a patient that's planning pregnancy, then but they aren't pregnant, they need to be advised that they can't have an ACE inhibitor, and then they would need a GP appointment to discuss an alternative. Decompensated heart failure. So basically, because of low cardiac filling pressures, if you then give them an ACE inhibitor, you're reducing the amount of ejection coming from the heart, and that can give them much lower hypertension and make them unwell. So the structural abnormalities in the heart, so aortic stenosis, if you're reducing the amount of afterload, which is what ACE inhibitors do, again, you're likely to drop their blood pressure even further and make them unwell. Renal artery stenosis, I've put a star in there because that is to to your attention that this is a secondary hypertension. So these are the causes that would need to be managed in secondary care. But if you're aware that somebody has a renal artery stenosis that has been picked up when that from it's hereditary and they have high blood pressure, then you would refer them on to secondary care. And then heart failure. So Entresto is one of the pillars of heart failure management, and you can't initiate ramipril within 36 hours of the last dose of Entresto. However, if they're on Entresto, it wouldn't be something that we would be managing. It would be a GP. And then renal impairment. So ACE inhibitors are nephrotoxic, and if people with renal failure are put on them, it can make their GFR even worse, and it can give them an acute kidney injury. So you would not be prescribing ramipril to somebody with renal impairment. Okay, so dosing. So first line currently is ramipril, and you would start with, for your generic patient without diabetes, you would start them on 2.5 once a day, and that is after you've got a set of UNEs so that you know that they don't have any acute kidney injury or renal failure. In patients with diabetes, you'd start them on a much lower dose, 1.25. And then patients with diabetes but with at least one cardiovascular risk, you would put them on 2.5. And then with all patients placed on an ACE, you would bring them back in 2 weeks. You'd recheck their blood pressure. You would want to do another set of UNEs just to check that there's been no change in their renal function. I can't see the chat, so, or can I? Hang on. I don't know if there's any questions yet.
Nothing in there yet, Lucinda.
No, okay. I might have to have you on it, Nick. Okay, so angiotensin receptor blockers. So if somebody's intolerant to an ACE, if they either have renal impairment or they develop the ramipril cough, which is quite common, or it makes them feel unwell, dizzy, sick, and they can't tolerate it, then you would prescribe a angiotensin receptor blocker. So it's for under 55s that are intolerant to ACE, and it's an adjunct to Afro-Caribbean heritage patients that are hypertensive, and that's of any age. So angiotensin 2 receptors are found in the cardiovascular system. They're found in the endothelial cells of the arteries and arterioles, and essentially you're blocking the receptor that allows angiotensin to exert its vasoconstrictive action, and so you get vasodilation. So again, we're going to come back to this. So we are vasodilating, but secondary to that, you get fluid loss from retention of salts. So you're reducing blood volume and you're also vasodilating. Again, ARBs are on the list of drugs that if they're unwell, then with GI upset, vomiting, fluid loss, if they have a stoma and their stoma is particularly overactive and they're unwell, then you need to be telling them to omit that dose until they are better. Within this presentation, I've embedded some videos, really short videos that I found that basically explain how each of these drugs work. So the mode of action is essentially within this endothelial cell. So this is the wall of an artery. This is an AT1 receptor. Angiotensin normally binds to it to constrict, and the ARBs will block that and won't allow that to work. And so you get vasodilation. But it doesn't have any effect on bradykinin. So you don't get the same effects as an ACE. So there's no undesirable effects like edema. So it's a good alternative if patients are struggling with edema or leg swelling in the summer, or will go on to amlodipine if they're struggling with amlodipine and they don't like the edema in their legs, which is a common side effect. So considerations for ARBs. So we need to be very careful with anybody with a gastrointestinal pathology, stoma, colostomy, anybody that they might have an overactive stoma or they're losing fluid. So you would approach with caution. Anybody with CKD, it will exacerbate hyperkalemia. The potassium sparing diuretics. So the essentially the way that the salts are lost, you can essentially get an increase in potassium because you lose other salts. Liver failure. So there's been data to show that you can increase the plasma concentrations of ARBs because of the enzymes that break down the drug. When you've got liver failure, that whole system doesn't work as well. So you consider starting at a lower dose on these patients, but obviously the GPs that within your practice should be there to help you and supervise you if you have difficult decisions like this. Patients with heart failure, we've previously discussed that with ACE, but basically you can cause them to have a much lower blood pressure, and it can then cause ischemic events, so you need to be careful. And then HOCM, so hypertrophic obstructive cardiomyopathy, any aortic or mitral stenosis, you're basically going to reduce the afterload so much that you can cause them to have a much worsening hypotension and make them unwell. And then same as an ACE, the ARBs should not be given in pregnancy. So if they're trying to conceive, you'd book them with the GP to discuss their options. I have attached a couple of links in here at the bottom so that you can read about the considerations for patients with renal failure, and then renal function with people with heart disease and peripheral vascular disease. So you can go back and look at those. Okay, so
Lucinda, somebody's asked in the chat, do you have any info on fludrocortisone and postural hypotension?
I don't, but I can find some information. Do you mean in terms of Sophie, do you mean patients that you've managed them for hypertension, they then develop a refractory postural hypotension, and then they're started on fludrocortisone? Is that what you mean? What I do know is fludrocortisone is not normally started in, so it's not normally started in primary care as far as I'm aware, but I can ask that today. I can ask one of the GPs today. Do you also mean as in the how it works? Ah, okay. Oh, that's awesome. Okay, I don't know, but I can go away and find that out and put that into this presentation if I do it again. Okay, I don't know. If I'm completely honest, I don't know, but I can find that out and then add that in. Okay, can you see my screen now?
Yeah.
Yeah, okay, good. So we've done that one, we've done that one, we've done that one. Okay, so dosing. So I haven't put in the drug names for this because there's quite a few ARB drugs. There is candesartan, losartan, valsartan. So most people start on losartan. That's the one that most people choose. It's a once daily dose. and you'd look to increase it 3 to 6 weeks after initiation, which actually, putting this together, I didn't realise. I often change medications on a Thursday when I'm on call and people are coming in for their checks, and 3 to 6 weeks after they've initiated it. If they're diabetic, it needs to be left at least a month, and then you would bring them back to check that they are within range. With an ARB, you wouldn't need to check their U's and E's the same as you would with an ACE inhibitor. Okay, so calcium channel blockers. So these are, we're looking now at the right side of the algorithm. So this is for anybody over 55 and all ages of Black, African and Afro-Caribbean heritage. And then it's used as a second line, so an adjunct if I go back to, hang on, I'll go back to here. It's a second line if at step 2 or stage 2 you're not managing to get control of that person's blood pressure. So, hang on, let me go back to my slide. So, essentially reduces the amount of calcium entering the cells, and that causes smooth muscle to relax. You are not changing the blood viscosity, so there is no fluid loss, and so patients that present with having been on amlodipine for 6 months and now they're noticing leg swelling, it's because even though we are vasodilating, there is no fluid loss effect. So the amount of fluid is the same, and you get increased permeability of the vessels in the cell, so you get fluid leaking out. So that's one thing to consider, and also one thing to explain to the patient, that you are changing the pressure within their vessels, but actually the fluid's the same, and so that's why they're getting these effects. They can swap, but sometimes it's just a case of explaining that when they are resting, they need to have their legs elevated, and sometimes class 1 stockings can be helpful as well, especially in the warmer months when you've got that added warmth and vasodilation from that. Okay, so I did touch on this earlier, but because Afro-Caribbeans have this low renin response, that is why calcium channel blockers are your first line, because ACE and ARBs tend to not be that helpful or efficient. So there are 2 distinct chemical classes of calcium channel blockers. There are actually 3, but for the purpose of this, I have put it into 2 groups. So the most common are amlodipine, felodipine, licidipine, nifedipine, and nicardipine. They will basically reduce systemic vascular resistance, but then verapamil and diltiazem, they will they reduce peripheral vascular resistance, but they also slow the they have localized effects on the AV node, SA and AV node, and so that you get slowing. So verapamil is used to slow the heart rate, so you get a decrease in heart rate and a decrease in blood pressure. So they're useful for people with arrhythmias. So essentially, this is your cell, this side, and what you're doing is you're blocking the calcium getting through. Calcium, when it's within the cell, it is required for that contraction. So if it's not there, the muscles can't contract, and then you get dilation. And if you think about, I mean, I don't know everybody's kind of experience or previous jobs that they've been in, but the old ladies that come in with a low calcium that are dizzy, sick, feeling unwell, it's because when their calcium's low, because there's less of it, you get this vasodilation, low blood pressure, feeling generally dizzy. So that is essentially how a calcium channel blocker works, and it reduces the overall peripheral vascular resistance. It reduces the afterload. Okay, so considerations then for safe prescribing of calcium channel blockers. So again, there is aortic stenosis. Anything where you already have a reduction in afterload of the heart, and then you're reducing the blood pressure further, you're going to put the risk of having a much reduced cardiac output and drop their blood pressure much further. Anybody with an unstable heart failure, you can put an increased, because of that reduced blood pressure and because of that reduced afterload, you can have further cardiovascular events, and it can put them at risk of death. Liver failure, we've discussed earlier for the other drugs, but it's exactly the same. So because the way the amlodipine is metabolized, if you've got liver failure, then there is a delay in the metabolism of amlodipine or of calcium channel blockers, and so you get this increased concentration within the plasma. And so because you gain increases in that plasma concentration, you get a significant lowering of blood pressure. Okay, so intermittent use of drugs like, so macrolides are erythromycin and clarithromycin, antifungals, so fluconazole, PPIs are meprazole, and then protease inhibitors. These are the HIV drugs. So essentially the same pathway for breaking down of these drugs is the same pathway for calcium channel blocker metabolism, and so because of that they conflict, and you can get an increase in plasma concentration of amlodipine or a calcium channel blocker, and so the blood pressure can be forced to be much lower for a longer period of time. Grapefruit juice, we've all heard that patients should be advised, if they're on calcium channel blockers, not to have grapefruit juice. And again, it's this increases the bioavailability of calcium channel blockers. It's the same pathway within the liver for breakdown, and so you get a much increased blood pressure lowering effects. And then pregnancy, so we'll discuss that. So it needs to be approached with caution. There's no evidence to show the effects on the fetus, but it needs to be managed. Hypertension in pregnancy needs to be managed by secondary care. Okay, so I've just cut and paste this from the NICE guidance. So most people use amlodipine, and then you would check their blood pressure in 2 weeks' time. If it's still increased or still above the level of 140/90, then you'd look to increase it to 10. I listened to a podcast recently that said that you'll get about 80% response from the first dosing, and that actually you'll only get a small amount of improvement increasing that dose, and actually it's better to add in others. And the European Guidance for Management of Hypertension, which is different from our NICE, actually opts for not increasing but actually adding in, but our guidance says not to do that. So we would optimize first up to the highest dose and then add in other medications. So thiazides. So thiazides are your kind of step 2, step 3. They're quite a nice, easy drug because there is no titration. You would just add it in once you've put them on an ACE and a calcium channel blocker, or an ARB and a calcium channel blocker, and you're still not getting control, then you would add in a thiazide, and the same this side. So the way they work, so basically on the distal convoluted tubule within the kidney, they block the movement of sodium, so you excrete more you get a reduction in the reabsorption of sodium, and so you wee out more fluid. So when we're looking at our here, we're reducing blood viscosity, and that should reduce systemic vascular resistance. So again, I've embedded a video in here so that you can, and it's only short, all of them are only short, so you can actually see how that drug works. Okay, so I promise you we're nearly there. So as I said before, it's a fairly easy step because all you're doing is you're adding one tablet in, and there is no need to titrate it up. It comes in two forms. It will either come as a 2.5 milligram dose that you take in the morning, or if they're on a modified release preparation, it's just making sure that they have it at the same time each day. And you'd recheck their blood pressure within 2 weeks just to make sure that you've got it between below 135/85. Okay, so lifestyle changes. This is really important because anybody that's diagnosed with or given a diagnosis of essential hypertension, and they have a BMI of over 27 if they are from the BAME population, or 30 from if they are white heritage, they would automatically be referred to the weight loss management program, and that's on system 1, and that would be part of your assessment. So that would be offered to them, and there's a kind of a self-populated form that you just click on it, click that they've got hypertension, click that their BMI is over a certain amount, and then ask the secretaries to send it off to the digital weight loss program. The other thing, if you have a dietitian within your surgery, you can book them in with them to talk about diet, exercise, looking at changing the composition of their food that they're eating, asking them to reduce the salt intake. Obviously, salt can change the fluid balance within the body, and so by reducing the salt, you're retaining more fluid. You're not allowing that vasoconstriction as much. Reducing caffeine, that's really important. Increasing their fluid intake, and then reducing processed foods. So if you're reducing the processed foods, there's likely to be more salt within processed foods because it's satiating and makes food taste nice. And then exercise. So just advising them to move more. Now, I know this can be really patronizing and just say, oh, you just need to move more. But I often say to patients, if you have a smartwatch or on your phone, your steps are tracked on your phone. Everybody's phone will track their steps if it's on their body. Just picking a really low target, per day. If they're fairly sedentary, asking them to do 4,000 steps a day or 6,000 steps a day, and then slowly increasing it, because if you can increase your non-exercise activity thermogenesis, then you can reduce weight. So we're going to do some scenarios now. So unfortunately, you've got the answers because my slides don't work. So this is John. He is a 43-year-old male labourer. He's come in for a routine health check. His blood pressure is 158/90, and you've sent him away. He's done average readings. You've done some blood tests. You've taken his weight, and that's important, like I've just said, because of the weight loss program you can refer them to. You've done an ECG, and if you're trained to do it, you would do a fundoscopy. You've found that the average is at home is 152/89. There's no signs of end organ damage, and he's not a diabetic. So you would prescribe, hang on, where are we? I'm just seeing if there's any questions. You prescribe amlodipine, 5 milligrams once a day, and then you'd repeat his blood pressure in 2 weeks. Any questions about that? Nope. Okay. Oh, hang on. Is there one? No. So Joan, this is Joan. She's a 76-year-old female. She's retired. She's come in for her annual hypertension review. She had a blood pressure of 151 in the chair. She couldn't tolerate an ACE inhibitor because of cough, so she was put on a angiotensin receptor blocker, and she's now on the maximum dose. So what you would do is you do your blood test, ECG, urine ACR. Essentially, you're going to want to, with each intervention, you are going to want to check for that end organ damage, especially if their blood pressure is continuously high and you're not getting control. So there's no signs of end organ damage, and she's not a diabetic. So you would add in, so we go back to that lovely slide. So we are here. So she's already on an ARB and you're not getting control. So you would add in either calcium channel blocker or a thiazide. Okay. Okie doke, where are we? So there she is, that's Joan. All right, so this is Debbie. Debbie's 42 years old. She's a stay-at-home mum. She came for her pill check appointment and she was found to have a blood pressure of 155 over 83. And you've gone through the history because she's on that cusp of being only just over 40. You would take a history and make sure there's nothing suggestive of secondary causes. Again, I think I'll just send out my secondary causes slides out to you so you've got them as well, just so you can have that knowledge of what to think about in the back of your mind. So you've done your 7 days of readings and blood tests and your ECG and your fundoscopy and urine ACR. And so hopefully there's no sign of end organ damage. She's not a diabetic. And when you've asked about future pregnancies, she doesn't want to increase the size of her family. So because she's under 55 and because of her ethnicity, you're going to start her on ramipril after you've got these blood tests to check her renal function. And you're going to repeat her blood pressure in 2 weeks' time. If her blood pressure is maintained, lovely, and you've got it under control, then great. If it's still teetering around 145, 95, then you're going to increase the dose, and you do small incremental changes. So for this patient, I'd go up to 3.75 and then 5. So that's her. So then this is her twin sister, Dora. She's a customer service assistant. She was also found to have high blood pressure. But again, no secondary causes identified. Her average readings are done. You've done a blood test, ECG, fundoscopy, and urine ACR. There's no sign of end organ damage. She's not a diabetic. However, she would like another child. So these are the patients that you're going to say, okay, you're going to need to have an appointment with a GP to discuss your options of what needs to be done. Okay, so this is Molly. Molly is 85 years old. She's attended for her diabetic review. She's got a blood pressure of 161/85 and she is already on the maximum tolerated ACE. So she's on 100. She's on 10 of ramipril. And you've done all these. It's all fine. All her bloods are okay. Diabetes is well controlled. And that should say ACR acceptable. So let's go back to that lovely flow chart. So she's already on maximum tolerated. So you're going to add in a calcium channel blocker. I think that's what I've put. I hope that's what I've put. Yeah, calcium channel blocker once a day and repeat her blood pressure in 2 weeks to check that you've got it within range. Again, if you haven't, then you would look to increase it further to 10. So the last one. So this is Mike. He's 85. He's very happy to be 85. He's retired. He's a diabetic and he's attended for his diabetic annual review. His BP is not controlled at all. He's already on an ARB. He's already on a calcium channel blocker. and they're already optimized up to the maximum doses. So you've done his ECG, you've done his urine ACR, you've done his blood tests, you've done an MMT and a memory check and a fundoscopy, and everything's fine. So for him, you're just going to add in that thiazide once a day, and you're going to repeat his blood pressure and UNEs in 2 weeks. And that is us done. Have you got any questions? I'm going to go back to my slide. Sophie, is that a home BP reading? Oh, it's in clinic. So you'd bring them back to a healthcare assistant. Yeah. Obviously, if they can't get in, then you could do 4 days worth of readings. That's fine. But ideally, they need to be sat in front of you so that if you do need to change that dose, if you do need to increase it, then you can have that. I am sending them out. Yeah, you can have that conversation with them of like, okay, we're not quite under control at the minute. Let's look and see whether or not we need to increase the dose, and have that conversation with them as to why that dose needs to be increased. Okay, starting ramipril. Do we do? Yes. No. So I've been taught by the GPs that I work with that when you start it and you've got their UNEs in front of you before starting it, you would then repeat their blood pressure in 2 weeks and their UNEs in 2 weeks. And if they're controlled, wonderful. If they're not, then you would increase the dose and bring them back again. And with ramipril, normally it does take 1 or 2 titrations to get them within range. I mean, depending on the blood pressure, if it's only just over, normally 2.5 of ramipril will bring it down and within range. But if it's much higher, say 160 over 95, then you are going to need to dose them a few times in order to get that under control. But bottom line is, if you're any dose change, you need to repeat their UNEs 2 weeks after. I'll put that in. I'll add that into the slide so that it's clear. I can, well, I've been taught to, but I can, and there's nothing in the NICE guidance as to when, as in the when it should be done, but I've been taught to. So if you've been taught 4, I don't know why that might be, but I've been taught 2. But again, when I send the slides out, I'm speaking to my GP colleagues later, so I can just double check what I'm telling you is correct. But Chris is on. Chris is a clinical pharmacist. He may be able to answer. Here we go. Hello.
Hi. Go on. What might I be able to...
So the question is, when starting ramipril,
Yes.
do we check it at 2 weeks because their GPs, as in check UNEs at 2 weeks, or 4 weeks because the GPs have advised 4 weeks? But I've always been taught by Michael 2 weeks.
I don't think there's necessarily a right or wrong. To my mind, the most important thing is that you need to check it within a month of starting somebody on it. And ideally, you probably want to have some baseline UNEs before you actually initiate anybody on it, because you don't want to throw somebody onto an ACE inhibitor or an ARB if they've got compromised kidney function. Does that answer the question?
Yeah, it does. I'm just looking at this question. So when starting antihypertensives, do we do a UNE before starting? Yeah, you have to have a UNEs before starting.
Yeah.
If they haven't had a UNE within the last 3 months, then you absolutely have to have one. So I've had a patient that I've had to send away. I've taken her bloods that day. Luckily, their bloods hadn't gone. So I took her bloods and basically called her the next day. Okay. Elizabeth's, yeah.
The thing about this monitoring, Lucinda, is 99% of the time, patients are absolutely fine on it. It's not a problem at all.
Yeah.
But you just got to be strict with it, because as we've seen very recently at Park Avenue, started a patient on a statin, absolutely no problems whatsoever. Chased her, reminded her. 3 weeks later, her liver functions were completely deranged. So just, for every 100 patients you start on an ARB or an ACE inhibitor, and their kidney function will be absolutely fine. But just every so often, you find a patient who's got problems, you start them on it, and it just gets worse. So you've got to monitor it.
Yeah. So, Elizabeth, I will go and ask our GPs. Obviously, you can ask your GPs as well, but I will ask, because I've always been taught 2 weeks, but maybe there, as Chris says, maybe there is kind of maybe 4 weeks is the maximum. But yeah, and I'll come back to you. It may well be that I've been taught to be overly cautious. I mean, we do work with quite cautious GPs, don't we, Chris? So,
We do.
Any other questions?
Very thorough GPs.
Very thorough. They are very thorough. Is that what you said?
Yes, very thorough and very specific and good attention to detail.
Yeah. Any other questions? Sorry, it was a bit waffly in places, but the videos I have put into the slides are they're useful. They're only short. I think the longest one is 6 minutes, and it just, for me, just helps for you to have a well, I'm a very visual person. If I'm being taught something, if I can see it and I can see how it works, then it tends to make much more sense to me. So can I just say thank you so much for bearing with me? I know that it's not been plain sailing, and this seemed to happen last time when I did the minor illness. I couldn't get the slides to work and my video was slow, so I apologize if it was a bit tedious right at the beginning. But yeah, I'll send all the slides out, and I'll also send a little MS form so that if you can fill it in for me, and then I can send out a certificate of attendance. So although there is no guidance at the minute as to how much CPD we need to be having, across kind of the region, other people have been doing 6 hours of CPD a year. So this update would count towards 3 if you stayed for all 3 sessions. And the other, I was speaking at the lead nurse meeting this week. There is another prescribing update e-learning called Script, which is it's run by Health Education England, and it's basically modules, so you can pick your place of work, so primary care, and there is prescribing for pediatrics, so viral illnesses, prescribing for dermatological conditions, and it's really thorough and will give you CPD points at the end. So if you're having a CQC inspection and they need evidence of your updates, then you have that to show them. The other thing is that when you're on shift, there needs to always be a GP that takes responsibility for any non-medical prescribing questions. So for example, Rachel, if you were like, oh, I'm stuck, I need to work out what to do with this patient, there needs to be an assigned GP that is supervising, especially if you're a new prescriber, to be that kind of soundboard and I suppose governance and patient safety. Okay, so thank you so much. I'm really grateful for your patience. And then the next session is with Chris, and it's covering practical prescribing in the menopause, which is brilliant. It's a really good session, so enjoy it. And yeah, I'm up for any feedback, anything that you think would be useful, anything that you think we need to change or add, just please email me, let me know. I'll be really grateful. Thank you. Over to you, Chris.
Oh, is that good? Can you see my slides now?
Yeah, beautiful.
Perfect. Right then, without further ado, we'll crack on. My name's Chris. I'm a clinical pharmacist. I have the absolute pleasure of working on a almost daily basis with Lucinda down at Park Avenue and King's Heath Surgeries. I've been here now for in the region of about 4 years. They keep letting me come back every day for some strange reason, so I must be doing something right. I'm going to talk to you today about menopause, a practical update, how to look at things, how to deal with patients. Yes, I've been on quite a few courses, but a lot of my HRT menopause, perimenopause solutions, for want of a better expression, and also, as you'll see from this little session, is based on real life case studies, interacting with perimenopause and menopause ladies, and dealing with patients in the best way possible. So, how to manage the menopause? A number of the slides here are overlapped and pinched from a presentation I did down at the Pharmacy Clinical Congress at Excel in May. But I've also added some case studies in and added a few little tweaks. So we'll talk about the burden of menopause. I'm going to emphasize how important it is to know your stuff, because a lot of the ladies that you end up speaking to are very, very knowledgeable. Talk about the difference between sequential and continuous regime. Quick mention about testosterone. It would be only appropriate to talk about that, and it's off license, but we need to mention it. Talk about some options for switching between different formulations, some practicalities, when to refer, and a few top tips. So, a little bit before we dive in and start talking about the practicalities, a little bit about the sort of overview. We define the menopause as once a female patient hasn't had a period or bleed for 12 consecutive cycles. And it's important to remember that this is 12 consecutive cycles, because not every lady who has a 28-day cycle. So we need to be mindful of that. The other thing as well is the average age for the menopause in the UK is 51. Most ladies go into the menopause and start going into the menopause about the age 50, but that's a bell-shaped distribution curve, and it's an average. And there are various ethnic variations. Certainly, in the Indian subcontinent, patients start to go into the menopause at the average age of 46. And here are some of the sort of definitions. Premenopause, perimenopause, these fluctuations and variations any time between the age of 45 and 50. Menopause is when patients have not had this period for a year or 12 consecutive cycles. And then postmenopause. And all of these have symptoms that we'll get into and talk about in a little while. So there is quite a burden on society and nationally. And this was from a really good set of surveys that the British Menopause Society conducted a few years ago, about 8 years ago. So nearly half of patients in the menopause said that their symptoms were worse or much worse than expected, and over a third said that menopausal ladies said that their symptoms affected their work-life balance. So it does have quite a big impact on society, workplace, relationships. One of the things I always emphasize to ladies when I'm doing these consultations is to say that for ladies that are going into the menopause, there's a lot going on in their life. They're mid-40s, early 50s. They're busy at work. They've got family. They sometimes have teenage, early 20s children who have associated demands with financial issues, with cars, with motorbikes, with boyfriends, with girlfriends, with housing, etc. They may well have elderly elderly parents who are starting to have living issues, dementia issues, etc., etc. So there's a lot of pressure before you start to throw in the perimenopause and menopause symptoms. It can be a challenging time of life. This was a study done by Louise Newson. I had the pleasure to speak to her and listen to her and see her a couple of weeks ago at a congress down in London. And she's a very interesting, very passionate lady. And she's done a lot with for furthering menopause. But these were some of the findings from this study, 4,000 ladies in this age group, that 70% had mood changes. Nearly 3/4 of them patients had brain fog, and you often hear ladies talk about this. I'm mid-sentence and forget what I'm saying. I'm really struggling. I'm a teacher. I need to be sharp. I need to be on the case. Over 50% have got low libido. Again, nearly 70% of patients come back with weird and wonderful joints and aches and pains and stiffness, and they have these sort of weird and wonderful issues going on where all of us have been fit and healthy, been running marathons, doing 10Ks regularly as clockwork, and all of a sudden they can't run for more than a couple of hundred meters, and there's pain and stuff. So there's a lot going on, and the mood changes, brain fog, the mental health issues, and the sort of associated issues and anxiety to do with that. These tend to be the main thing, the main drivers. Yes, the vasomotor symptoms, the hot flushes, the sweats, etc., are an issue, but it generally, in my experience, it tends to be, I can't remember things. I'm very, very anxious. I'm really snappish. I know I'm being horrible, but I just can't help myself. All of the above. And when I was just double checking these slides this morning, I suddenly remember there was a couple of useful graphs, and I remember listening to earlier on Lucinda talking about being a very visual person, and I'm a very visual person. So you see that for many years, patients' menstrual cycles don't vary much, but you'll often hear this. 45, 50 patients will turn around and say that their periods suddenly go out absolutely like clockwork for decades, and then all of a sudden they get into this perimenopause phase and they start to become shorter, lighter, longer, weird, heavier, etc. So this can be a good trigger, is if you're finding that patients are suddenly finding their periods are suddenly now 35, 45, 60 days in between bleeds. And again, another useful graph here, we see estrogen levels, progesterone levels start to tail off after the age of 35, which is one of the reasons why fertility starts to drop off. And we get into this perimenopause phase from about, say, 40 years onwards, 40, 41, 42. The estrogen levels fluctuate, the progesterone levels fluctuate. We see that testosterone starts to taper off as well, but also the melatonin as well. And this can be one of the main factors for sleep disturbances, where patients are waking up at 3 in the morning and absolutely wide awake. So we relate this back, and this is quite old. This has been from NICE, if memory serves me right. This was 2019, so it's been around for 4 or 5 years. But they're quality statements. And Statement 1, women over 45 years should be diagnosed with perimenopause and menopause based on the symptoms alone. You don't need lab tests. If you've got patients under the age of 40 presenting, yes, you should be doing bloods and follicle stimulating hormone bloods to try and look at and understand if a patient's got premature ovarian insufficiency. POI, patients must be given HRT and or possibly a combined hormonal contraceptive. Women who are initiated on treatment for menopause symptoms must have a review after 3 months. And you'll often find after 3 months, it's there or thereabouts that ladies do start to feel a little bit better. It's taken a while for the hormone levels to get back up again. And interesting fact to hear that ladies who've gone through a surgically induced menopause, i.e. they've had a bilateral salpingectomy, oophorectomy, they've had a hysterectomy, they've been given chemotherapy, they're on some DMARDs, etc. They really need to be given as much information as possible about menopause and fertility before they have their treatment. And we do see this sort of hormonally. Ladies are absolutely fine, and all of a sudden they go in for a procedure and the hormones drop off the face of a cliff, and all of a sudden they're feeling absolutely rubbish with life. So It's really important. I really emphasize that if you're going to do HRT menopause consultation, you've got to know your stuff. You've got to know your stuff clinically. You've got to know your stuff formulation wise. And I'll come on to an example of this a little bit later on. But options for learning, you've got the Morphs Women's Health Academy. I've been involved in some of the bits to do with that. Morph do lots of face-to-face training events, including the Clinical Pharmacy Congress. They'll also do respiratory and ADHD and lots of other updates as well. There are some very good BMS and Faculty of Sexual and Reproductive FSRH courses. They're quite expensive, but they're very, very worthwhile. The British Menopause Society also do a series of training dates and updates as well. There's the Sarah Gray online course. There's the 14 Fish, which has now morphed into the Newson Academy. That's just come through. Again, potential cost, but also really, really good. And a lot of the stuff that Louise Newson does is not just clinical, but it's related to individual consultations, talks about very specific presentations, and gives a really good feel for and a really good understanding of how to deal with particular patient consultations, particular patient problems. Don't forget also as well, consultations and shadowing. One of the biggest learns for me has not been the online stuff, has not been the courses I've done. It's been sitting, listening to, talking through and understanding and sort of soaking up over a period of a couple of years what ladies in the perimenopause and menopause have had to say to me about their symptoms, how they're feeling, the effects on their quality of life, etc. And I'm very lucky. I work with a couple of very good, excellent menopause practitioners, Dr. Liz Allen and also Kate Kehoe, and it's great bouncing ideas and talking through different cases with them as well. And the reason I emphasize about knowing your stuff is, apart from making sure that you're credible for your own benefit, but patients will want to push and ask and question. And this was a good example. This BMS unscheduled bleeding on HRT document came out. I think it was released something like the 23rd of April, which was a Monday. And by chance, as I always do, I always have a poke around on the BMS website once a week just to see what's going on. Had a quick look see on the Monday. Wednesday, I was across at Budbrook Surgery, and a patient walked in, sat down and started talking to me about this and saying, I'm on a particular forum. The particular forum is monitored and facilitated by a GP. She's read these guidelines and she recommends we should be on a higher dose of progestogen. I was like, oh, okay. So where I was going with this is a lot of ladies that will come to see you, whether it's for initial consultations or for follow-up consultations, will undoubtedly have spoken to, done their research, be on top of it all. They'll know what's going on. So it's really, really important that you know your stuff as well, to give credibility and to be able to counsel and support these patients as best as possible. Other two good resources that you can find. This is a big A4 book. Obviously, this is the one I bought a couple of years ago, so it's slightly out of date. There's a more up-to-date one. When you join the BMS, you get this little book. This is a little A5 book. Unfortunately, I've lost mine, so I need to order another one. The BMS book is very technical and very detailed, so it's not something you'd necessarily want to read cover to cover, and you can just sort of dip into it every now and then. The Hot Topics for Women is an excellent resource because not only does it go into perimenopause, menopause, testosterone therapy, it gives a nice little algorithm for patients that have got a uterus, patients that haven't got a uterus, patients that are still having periods, that are still aren't, etc., and the combinations, etc. But it also touches on contraception and genital urinary symptoms, etc. It's a nice, easy to dip into, pick up side of things. So right at the beginning of this series of webinars, I glanced at and listened to Philippa talking about shared decision making, and HRT, perimenopause, menopause, initial follow-up, all of these consultations demand and need a shared decision-making process, because it's this collaborative process where you're working with a patient as a healthcare professional. You're working together to reach a joint decision about care. And it sometimes comes across as a bit corny, but I genuinely believe it. When you're dealing with perimenopause and menopause ladies, they're their own expert. They know what works for them. They know what's good for them from a routine perspective. You know, and I'll often find this with patients. They'll turn and say, you know what, I haven't got time for gel. I'm too busy to put this on in the mornings. I'm too busy with the dogs, the kids, sorting my horses out in the morning. I can't be bothered with that. Equally so, they'll turn and say, no, patch won't work for me because I get very, very sweaty when I'm mucking the horses out, and then I head off to the gym and go for a swim as well. So it's not just about the type of HRT, whether they want it, whether they need it, but it's also about the formulations. And, you know, I often say this, again, as part of a shared decision-making process, that, you know, this is the start of the journey. Try this. If it works, great. If it doesn't, come back and we'll switch formulations or look at options. It's very much not a, here's some medication, go away, don't come back again. It's an ongoing process. And what you'll often find is, I've found this over the last couple of years, in particular with some of the patients I see across at Bugbrook, that ladies are often stored up their feelings, their emotions, their symptoms for somewhere between 6, 9 months, even a year. And there's quite an outpouring. It's quite a big thing when they come to speak to you. So you've got to be patient, you've got to listen to them, you've got to be supportive, as I'm sure all of you will be. So things you need to think about when you're running a menopause. Who are the patients you want to reach? Are you going to need some translator services? Trying to have in-depth emotional conversations and consultations with patients, if their English isn't their first language, can be a bit of a problem. Are you going to reach out to these patients? Why should they engage with you? What are the benefits? So lots of factors to ask yourself before you start setting up a menopause clinic. So I thought I'd put together these sort of diagrams, schematics, and pictorial representations, because one of the big things that a lot of my colleagues and for non-menopause practitioners struggle to differentiate between is this difference between sequential and continuous HRT. So on the left-hand side of the graphic there is the perimenopause, and we define a lady of the perimenopause who is exhibiting symptoms of the menopause: hot flushes, brain fogs, night sweats, anxiety, etc. But it's perimenopausal because they're still having periods, and these periods can still be very, very regular. They can be light periods, they can be very heavy, they can be clotting. And this perimenopause phase can last for quite some time, 5, 6, 7, 8 years. And in light of that, we would suggest, and the guidelines would recommend, that we put a patient on sequential HRT, which is always having estrogen, but having some progesterone or progesterone in the luteal phase, i.e. the 2 weeks leading up to the period. So we mimic the natural rise in progesterone. So they'd always have estrogen, and from days sort of 12 to 26, they have 2 weeks worth of progesterone. In theory, and the recommendations are that that continues until a patient is no longer having periods, and they've not had a period for a year, and at which point they go on to continuous HRT. So that's still having some progesterone and estrogen every day in combination. But it's a grayscale, and it's an overlap, isn't it? And certainly this was something I discussed with Louise Newson, which is practical approach has shown over the last couple of years that for ladies that are sort of 49, 50, 51, 52, is if they've been on sequential HRT for a number of years, you can almost see that the period is being produced as a withdrawal of the progestogen. So you've got this sort of continuum, and the document that I looked at and showed you earlier on of unscheduled bleeding does from the BMS does very specifically now recommend that if patients have been on sequential HRT for more than 5 years, that they switch over. And this is where, as I said, we talk about, and that's the recommendation about the BMS side of things. So we go from sequential to continuous, and continuous, as the name implies, is a dose of estrogen, a dose of progestogen every day, and the same medication every day. There isn't this variation. So, good example of sequential. Patients have Everil Sequi. If you open up a box of Everil Sequi, it's got 4 Conti patches and it's got 4 Everil patches in it, Everil 50 patches. The Everil Conti is estrogen and norepinephrine, so it's estrogen and a progestogen, whereas the Everil 50 patch is just estrogen on its own. And our recommendation and all the evidence points to the fact that wherever possible, if we can encourage ladies to have transdermal estrogen, i.e. as a patch, a gel or a spray, it's going to reduce the risk of blood clots. And certainly with transdermal estrogen, there's no increase in VTE risk. And it's to do with the fact that oral hormones get absorbed, go through first pass metabolism in the liver, and in doing so can affect the clotting mechanisms. And again, other options for sequential are either the pump or the gel as individual sachets, plus the micronized progestogen capsules. There's now a new version on the market, Gepretix, which is a little bit cheaper. You know, when you read the BMS unscheduled bleeding, there's now a recommendation to increase the amount of progestogen that patients are having. So if a patient's on 4 pumps of estrogen or 3 or 4 milligrams of Sandrina gel, i.e. more than a couple of sachets a day, then they should also be having 300 milligrams at night of estrogen if they're on sequential regime, 200 milligrams every night if they're on the continuous regime. So that's the sequential. Continuous, the Everil Conti patches, as I said, estrogen and the progestogen. And you can get the similar option with the gels and the capsules. You just take them continuously. So onto the thorny subject of testosterone replacement. The big thing to bear in mind is that all testosterone therapy in the UK is off licensed, and if we're brutally candid, it's probably going to stay that way. When I've asked the question to various pharmaceutical companies, in particular Bessins, who I do some work with, the senior chap there was very candid and said, there's nothing to be gained by us by licensing testosterone for female usage in the UK. It costs millions to get the licenses through, and it's all off license. So if you are a prescriber and you are running HRT clinics, yes, consider testosterone. Again, know your stuff, know the blood tests, know the guidance that's in here from the BMS, but just be aware that it's all off license as well. Lou, any questions at all so far from anybody? I've not had a chance to look at the chat box.
I can't see any other than somebody's just messaged me separately saying they could, my mic was on, so I'm sorry if that was distracting.
No, not at all. It's fine. Please feel free to ask any questions into the chat box, or just speak up. I'm just conscious that I'm presenting, but it's an open learning forum, so please feel free to ask any questions if there's anything that I've missed. So testosterone therapy, the most important thing before you dive in and start giving patients testosterone or even talking about it is you've got to make sure that a patient is stabilized on and suitably estrogenized in terms of their HRT. If you've gone up to relatively high doses of transdermal estrogen as patch, gel or spray, and a patient's still not feeling any better, you've got to raise the question of, particularly if they're very, very slim, are they absorbing it? There is evidence to show that ladies with a low BMI, i.e. below 22, 23, may not necessarily absorb the gel particularly well. There's also, as well as there's this inverse proportionality between a patient's BMI and their levels of sex hormone binding globulin. There's nothing that can be done about that. So when you're doing bloods, you need to try and work that one out, because if a patient's got a very, very high level of SHBG, they may not be they may be absorbing estrogen particularly well, but it may not be available. And I always give the analogy to patients about SHBG that it's one of those things. It's like, these multimillionaires who you'd go to and say, look, can you lend me 10,000? I'm really skint. And they say, love to, but all my money's wrapped up in property and cars and shares and stocks, etc. And that's what SHBG does. It will locks away and makes the hormones, estrogen, progesterone, testosterone, unavailable for use in the body. Now, the classic nice guidelines indication for testosterone is for low libido. However, in my experience, the big thing that makes a big difference to patients is this level of energy. And if they've got low energy, they've still got a bit of brain fog, they're not as sharp, there's not as much clarity, not as much vavavoom, this is where they can really benefit from testosterone. Before you dive in and give a patient testosterone, you've got to do some pre-TRT bloods. As I said, SHBG, FSH, estrogen, testosterone. And if a patient's feeling really tired all the time, it's not unreasonable to do sort of, folate, VitB12, FBC, thyroid bloods, etc. Once you've done these levels, you can then calculate this free androgen index. It's dead easy. You just take the amount of testosterone in terms of micromoles, put it over SHBG. That gives you a number, times it by 100, that gives you a percentage. For appropriate levels of testosterone, it should be less than or equal to 5%. If it starts getting up to 8, 9, 10%, a lady has got too much testosterone, and you risk some long-term issues. And the daily dose is less than or equal to 5 milligrams a day. So be aware, this is 10%, 1/10 of the male dose that a patient might need. So just be mindful of that. And you need to do follow-up bloods and monitoring approximately every year once you've got a lady stabilized. And you've got different options for testosterone. It does vary depending on stock situations. The thing you've got to know is you've got to know your dosing, though, and work it all out. So the Testogel sachets, they have a total of 40 milligrams in them in the total sachet. So one sachet needs to last 8 days. 40 divided by 8 is about 5. And you can see that the sachets have got this little spout mechanism built into them, so you can squirt a little bit out, rub that in. The thing I always say to ladies is that when you first start using something like the Testogel sachet, it may not be that easy to sort of work out, how much have I used, how much am I using, etc. One sachet needs to last 8 days. It's as simple as that. And if they get to day 6 and they've used it all, just have a couple of days, because it's about area under the curve. So it's 40 milligrams over an 8-day period, average dose of 5 milligrams a day, but with a blood test after a couple of months just to check on the levels. The Testogel pump is 1 pump every 4 days. The Tostran is 1 pump every other day. And again, both of these will give that level. You've got to be dose flexible, which is that sometimes you can give Testogel sachets to a lady, and despite the fact they're only using 1 sachet every 8 days, you get the bloods back and their testosterone levels are too high. So you might have to go to 1 sachet every 10 days. Equally so with the tostran, you might find it comes back at that because, it's a different dose of ladies will absorb it differently, metabolize it differently, and therefore the blood levels will be different. You might find you have to make 1 pump every 3 days. For the tester gel, it might be 1 pump every 5 days. So you sometimes have to vary and adjust the dose, but it's important that you understand how much is going in terms of milligrams, and it must not be more than an average of 5 milligrams per day. So stock issues. I'm sorry, that's squeezed through. That shouldn't be there. So please ignore that. That's from some work that I've done with Morph. With stock issues, there's this very, very good document that the British Menopause provide for HRT preparations and equivalents. You can use this to help you provide an alternative because we have had all sorts of issues with stock issues over the last few years. So one of the biggest issues about stock is it's often propagated by hoarding, and a lot of the hoarding is self-perpetuating. We saw this 2 years ago, didn't we, with the petrol situation, where there was rumours circulating that petrol was going to be in short supply. So everybody who normally filled up their car once every 3 weeks went out and filled up their car, and of course there was no petrol because everyone was driving around with full cars with the petrol. And we've seen a similar thing with some of the prescribing. And before the HRT prepayment certificate, we had a number of patients who would specifically ask for 3 or 6 months of medication because they couldn't afford the payments. So just be very careful. I'm very strict and say, no, you get 28 days at a time, maximum maybe 2 months worth if you're going away on holiday, because if not, all that can happen is patients end up with 2 boxes or 3 boxes of Utrogestion sitting on the shelf at home and a couple of pump gels of Estrogel. Meanwhile, ladies are going without. In terms of the patches, Everil, Estradot and Estroderm are all equivalent. They've got 25, 50, 75, 100 microgram patches. The release mechanisms are slightly different. The sizes are slightly different. Estradot are a nice little octagonal shape. The adhesives are slightly different. So if a patient's getting application site reactions with Everil, you can change them to Estradot or Estroderm if it's available, and they may not have the same reactions. Bear in mind that the Fem7 patch, first and foremost, it's a weekly patch. Secondly, it's got a different progestogen in it as well. It's levonorgestrel, it's not norethisterone. So there's good options with Fem7 in terms of patients having it on a weekly basis, but more importantly, a different type of progestogen. So in terms of equivalence, Everil 50 is the middle dose. It's 2 pumps of Estrogel. It's 1 milligram sachet of Sandrina. Equally so, the Everil 25 is a 0.5 milligram dose of Sandrina. And we've got Utrogestion, we've got Gepretic, so identical. And then if you absolutely have to, you could go to Provera 10 milligrams or Norethisterone 5 milligrams for 12 days out of the 28 for the sequential side of things. For those of you in Northampton, I think most of Northamptonshire is on EMIS, and we're certainly at the moment we have the Ardens templates. I always encourage and enthuse about Ardens templates because I think they're great. They're a good tick list. They help you remind you of things to ask, questions to go through, but more importantly, they help you code particular symptoms and issues into a patient's record. It's always slightly ironic that one of the big things that a lot of ladies talk about with menopause and HRT, etc., is brain fog, but there is no read code for brain fog. The nearest you can get is effects on mood. That's always slightly ironic. Again, more of the Ardens templates. Try and use these to record uterine status, bleeding status, etc. and never, I'm a great fan of these. I think they're a brilliant way to help you code all the information in. And of course, if you want to use a scale to record patient symptoms, you've got the green scale, the climacteric scale, which is 22 questions asking a lady to rate her symptoms. And last but not least, always, always, always at a first consultation, do a VTE risk assessment. For most patients, it's quite low because most patients are not on a combined pill. Most patients are not necessarily morbidly obese. They're not traveling. Most patients have never had a first degree relative who's had a VTE, etc., etc. But you've got to document it because it shows that you're looking at and thinking about the risks associated with giving exogenous hormones. And don't forget also as well, particularly for older ladies, generally speaking, in my experience with perimenopause, genital urinary symptoms are limited. The sort of tearing, dryness, soreness, lack of lubrication, discomfort during sex tends to be for ladies over the age of about 54, 55. But it can happen in younger patients as well. And the vagina, the vulval region, everything in and around there needs a good supply of estrogen to stay lubricated, to stay flexible, to stay healthy. And if a patient is struggling with GSM symptoms, we can provide them with estradiol pessaries. We can give them a ring, the estringing ring. We can also get them some cream. And there's also, as well, there's now a thing called the intrarosa pessary. This is a combination pessary that it's some analog of estrogen and testosterone that gets metabolized and broken down, absorbed into the vulval and vaginal region to release quite a lot of estrogen and a small amount of testosterone as well. So that's another option. The only thing in Northamptonshire you've got to watch is quite expensive, and I can't remember if it's actually on formula or if it is, it's sort of second or third line. So a few things to think about when you're setting up clinics. A lot of the time it's other priorities. Is a perimenopause clinic higher on the list of priorities for your practice? You need to engage with the patients. We as pharmacists, we need to understand the role within primary care, both of a pharmacist with an interest in menopause and HRT, but also everything that's going on with it. You need to have good clinical development to make sure you're up to date with everything. Other things to think about, supervision. I heard Lucinda talking about this earlier on about non-medical prescribing and the fact that there needs to be supervision. There always needs to be, if you're doing a menopause clinic, a way of having on-site, easy access ways of escalating it, getting some supervision, getting some input, etc. And I find it very therapeutic and very cathartic to be able to go and talk to colleagues and say, I've tried this, I've done this is what's happening, what do you think? Just to bounce out and verbalise the idea, symptoms and patient, do a case-based discussion, even if it's an informal one. And also, as well as you then need to know how to escalate if there's notable issues for a patient. So, coming on to the last few slides, when's the right time to refer? If a patient is having notable heavy clot-like bleeding or flooding, if it's carrying on, they're having to change 6, 7, 8 times a day, that's a good time to refer to obs and gynae. If the patient's got a family history of breast cancer, particularly if it's hormone responsive, that is not a sort of patient that we should be dealing with in general practice. They need to go off to the gynae team. And if a patient's got this past medical history of high risk hypercoagulability, protein S, Leiden 5, antiphospholipid syndrome. Endometriosis, adenomyosis, fibroids can be worsened by HRT, so you've just got to be mindful of that. Even if you don't necessarily refer a patient to that, then to obs and gynae, you might just want to get some advice and guidance. And again, if patients are getting not having response, there's no response despite topical vaginal estrogens, they're having recurrent UTIs, that's when we need to get them off to the urogynae team down at Northampton General. And if a patient's having really, really severe, debilitating migraines, either with or without HRT, again, that's either a gynae or possibly a neurology referral. So, last couple of minutes, my top 10 tips for running a HRT menopause clinic. Like I said, know your stuff, the clinical stuff, the anecdotes, what works well for patients, what doesn't well. There's lots of acronyms, BSO, understand the difference between a total abdominal hysterectomy, a partial hysterectomy, and the subsequent sequelae of that. You've got to know your stuff. You need to be familiar with the different formulations, the packaging, the sachets, what comes in a box, what it looks like, etc. I'm very lucky. 1 day a week I work at Bugbrook, and I can wander into the dispensary, have a quick poke around, look at the sachets, look at the colours of the boxes, and understand what's going on. If you don't have that facility, I would encourage you to go and smile nicely at one of your local pharmacies, community pharmacists, and just say, look, can I just have a quick look for my own benefit at some of your HRT? The other thing as well is people like Bessins, people like Gideon Richter, Gideon Richter provide the Lenzetto spray, which is a slightly more expensive option, but does work very well for some ladies. They put it on the arm and go, and it seems to dry a lot quicker than the gel as well. All of these companies will provide you with placebos. In fact, here's one I produced earlier. This is a placebo version of the Lenzetto spray, and it's very straightforward. It just goes on the arm and gets sprayed on like that, and it does produce a little sort of thing. So that's a good option for you.
Do you have to rub that in?
Sorry?
Do you have to rub it in?
No, you don't. You just literally, I'm not really sure if you can see it on there, but you just hold it on and spray, and it just makes the arm just a little bit sort of damp, little low of moisture, and then within literally 2 or 3 minutes, it's absorbed. So no, you don't have to. Understand the local formula and prescribing guidelines. We are very fortunate in Northampton. There's nothing we can't prescribe, including testosterone. You go over into the border in Cambridgeshire, you cannot prescribe testosterone in primary care. It has to go through secondary care. You know, if you're just starting your HRT and menopause journey and clinics, ease into them just by doing HRT reviews. It gives you a good way of being able to start to learn and understand these things. We've talked about incessantly about the Ardens templates. Understand the patient resources, the green climacteric scale for scoring systems. Promote the prepayment certificate. You'd be surprised how many patients still don't know about it, despite the fact that over 500,000 ladies have signed up to and purchased a HRT prepayment certificate in the last year or so. There's lots of tools and resources out there. BMS, FSRH, Bessins do a superb a menopause HRT resource pack. Gideon Richter do some good bits as well, and so do Theramex as well. There's lots of really good resources out there. Try and get yourself a buddy or a mentor, someone you can talk to so you're not working in clinical isolation. Do your own follow-ups, and then you get continuity of care. And last but not least, my recommendation, join the British Menopause Society. So that's bang on time. So if anyone's got any questions, I'll do my very best to answer them. Thank you for listening.
Impeccable timing. Well done. Thank you very much. Any questions, anybody? I have one. In terms of testosterone.
Use your top.
I have on cold. Sorry.
I'm in Chimney's room and I was feeling a bit cold. But yeah, go on, fire away, lady. Sorry.
So my question is, in terms of things like testosterone, how quickly will they see an improvement in their symptoms?
Okay. With HRT, generally, it can vary enormously. Most ladies will tend to see an improvement, particularly for the estrogen depleted sort of issues, the brain fog, the anxiety, 3 to 4 weeks. Testosterone can take a little bit longer, and the usual recommendation is it can be up to 12 weeks with testosterone before they start to see a difference. But generally speaking, my experience is with the estrogen side of things, it's usually 3 to 4, 5 weeks before they see a benefit, and sometimes it can be life changing. I remember, and there's a case study I've got, which I can talk through another time, with a patient at Park Avenue, 44-year-old Danish, very senior marketing executive, spent half her life flying around the world. Saw her, started on HRT. She walked back in after about 5 or 6 weeks, shook my hand and said, I feel as though I should reintroduce myself because I feel like a different person.
Oh,
And I know it sounds daft, is you can make a huge difference to these ladies just by sitting and listening to them, because they sometimes feel like they're going mad because they're having weird and wonderful symptoms. I said, a lady I saw a couple of months ago at Bugbrook, I knew something was wrong because I was starting to upset the kids and they were worried about me.
oh, I mean, that it's massive, isn't it? As in, and also I think with the advent of Davina McCall kind of shouting from the rooftops, it's been way more people can talk about it now.
Yes, that's right. Yeah. And again, there's loads and loads of little quotes I've got, classic thing. I love my husband, but I just want to kill him half the time. I know I'm being an arsehole, but I just can't stop myself. One lady I saw at Bugbrook, I'm desperately anxious. I'm really, really worried. I'm really upset. I'm really scared. My best friend's husband's just left her because he couldn't put up with the symptoms anymore. I'm worried that's going to happen to me. So there's a lot of emotion and anxiety, and just having a empathetic shared decision-making process as the first consultation can make a massive difference. Even if the patient concerned wants to go away and have a think about it.
Yeah.
Don't make a decision today. Have a think about it. When you're ready, come back and speak to me and we'll start you on some HRT. Just that outpouring can make a massive difference.
Yeah, absolutely. Brilliant. Thank you so much. So obviously this has been recorded, but am I able to send them your slides as well?
Yeah, by all means. Yeah.
Yeah.
Do you want to email
if you
me?
ping them to me, ping them to me,
Yeah.
and then so yeah, this is being recorded, and it will be sent out. I am going to send out a very short 10-question Microsoft forms, basically to test your knowledge so that you can evidence that within your portfolios, within your revalidation, with your HCPC, for your renewals. If you need to show evidence, then you have that. Obviously, if you think of any questions afterwards, I work with Chris, so ping me an email or ping Chris an email, and he can answer any questions that you have. The next update will be planned for later in the year. We have got the non-medical prescribing conference, which will be sometime in September, but we are just discussing dates at the minute with the University of Northampton. So watch this space. It will be out in the newsletter most probably next month, to give people enough time to either book the day off or switch their days around. And then the next update will, after that, as in the targeted update, will most probably be October, November, December, so the last 3 months of the year. And I am looking for speakers currently. If you have any need in terms of if you're an asthma nurse, or you run diabetic clinics, or you're not happy with dermatology, anything you would like to support your prescribing, please email me, because I can find somebody somewhere. And thank you very much for listening. Thank you for your patience. And yeah, I will most probably get the slides out Monday now, because I've now got a load of emails to do. So yeah, thank you very much for listening, and see you all very soon.
Thanks for having me, Lou.
No worries. I will.
I'm going to drop out now because I've got to.
Yeah. No worries. I'm going to end it now anyway. So, thank you so much. I'm really grateful, and I'll see you soon.
Cheers, Lou. Bye.
Bye. I don't understand why I can't.